Brilliant. Okay, thank you very much, everybody. Welcome to the onboarding event for child-focused dental practice in London. Really, really great to have you all here. So thank you so much. I was going to do introductions, but there's quite a lot of us here, and I think we'll take a very long time to go through everything and who everybody is. So I'd be really grateful if you wouldn't mind putting your name and where you work in the chat, if that's okay, so everybody knows who everyone is who's in the meeting. So welcome. My name's Ushla Devalia. Everyone knows me as Ush. I'm a consultant paediatric dentist at the Eastman Dental Hospital. I've got lots of different roles, but for the purposes of this meeting, I'm project lead for child-focused dental practices, which is a scheme being run in London, East of England, and the southwest of England. So thank you so much for everybody expressing your interest, and we're really excited to start with you all here today. Thank you. Just so you know, for the purposes of the meeting as well, we have our team from the community services in Whittington and CLCH, and we have Andrew here as one of our commissioners, and we have some of the team from the Eastman Education Centre. So welcome to everybody, and thank you for joining us after hours as well. So hopefully we're going to have quite a swift agenda. We'll have plenty of time for questions at the end, of which I'm sure there will be many. If there are things you think of afterwards, please feel free to email us, and we have our email address. We can answer you directly. So at any point throughout the whole process, we're here to help you. So please feel free. I won't go into details about the agenda, but we'll go through a little bit of background in the project first of all and talk about the steps we need to do to make sure everybody's onboarded and on the same page going forward with CFDP for the next 6 months. Thanks, Jean. So our team here today is myself, Gulshana, who's on my screen on that side. G, do you want to introduce yourself? It's easier for you to do that. Thank you.
Sure, thank you. So my name is Gulshana. I'm a specialty grade dentist here at the Eastman, but I'm also the project manager for child-focused dental practices. I've had the opportunity to speak to quite a few of you last week and this week as well. So it's been nice to actually put some faces as well to some of the names. Thank you.
Thanks, Gulshana. And Minesh?
Hi everyone, I'm Minesh Patel. I'm the Associate Director of Dental Education at Eastman.
Brilliant, thank you. As we have the rest of the team who are here who are not being onboarded as a practice, if you don't mind, both of the Andrews and Andrea, do you mind just introducing yourself to everybody in the meeting as well, please? We go with Andrew B first, if that's okay.
Hi, good evening. My name's Andrew Biggerdyke. Most of you probably know me. I'm the regional lead for secondary community and specialist dentistry for London.
Thank you very much. And Andrew R.
Hi everyone, Andrew Reid, Clinical Director for Dental Services at Whittington Health Trust.
Thank you very much. And Andrea.
I'm Andrea Aspinall, Specialist Paediatric Dentist from Central London Community Healthcare Trust.
Thanks very much. Thank you, everyone. Okay, G, thanks. I know you've all had the opportunity to meet Gulshana over the last few weeks, and thank you so much to G for being able to do that. It's been a big task to get through all the practices, and apologies to those I haven't been able to meet on a one-to-one basis, but hopefully over the next few months I'll get the opportunity to spend some time with you all and have meaningful conversations about the project going forward. So we wanted to give you a bit of context into how the initiative started and how the development came about. We initially wanted to develop a project just in London, but with a lot of interest from other regions, CFDP has now kind of expanded nationally, and we have practices in the southwest of England, 7 in total, who have already started seeing patients. We have those in the east of England, specifically in the region of Norfolk and Waveney, and then we've got 10 practices we're onboarding tonight in London. So the concept started last year, and when we went through the slides, I can't believe it's taken a whole year, but it's been a lot of engagement and development to get to this point. So in December last year, we looked at a standard operating procedure and how we could specifically develop a programme that would be able to support practitioners in providing good quality oral health care for children within their region. And we wanted to find a training model that would be sustainable and be able to be easily accessible to practitioners without affecting their clinical working lives too much. So we conducted all of our stakeholder engagement from December up until probably summertime this year, where we developed all of the handbook, webinars, and our online learning package, which will be available on eLearning for Health for all of you to access. Our next aspect now, specifically in London, is December for us to go forward with our delivery of our clinical care. So it's looking forward to starting accepting patients once you've had the opportunity to access all of the learning that we have on offer for you. And throughout the whole process, you will also have access to peer support on a monthly basis, and that will be with specialists and consultants at the Eastman. Thank you. The handbook that's been developed has been in conjunction with Professor Paul Ashley at the Eastman, and I do have to say it's absolutely brilliant. All of the PEDS consultants at the Eastman who have seen it, everybody wants a copy for themselves, so really, really proud of what we've produced. It's a really easy to use guide, a step-by-step guide for all of the things that you will learn about throughout the onboarding guides and throughout the webinars. Step-by-step things that I think actually we'll be able to share with all our foundation dentists going forward. And it's a very succinct guide which links into the fuller resources. So please feel free to click on those resources and go and read the full guide if you wish for any of these clinical aspects. Just to mention as well that the handbook is available not only in the hard copy, but we also have digital versions, so you can easily access the links on your phone and or on your computer if you wish. So you'll all be getting a copy of this handbook coming in the post for you. Thank you. So we'll go through some details of the process of what it means to be a child-focused dental practice and everything in a step-by-step manner now. We hope we'll be able to explain everything and where you fit into the journey and where the patients are going to be coming from. But please, at the end, if you have any questions, write them down and we can go through those questions today as well. So the intention of the project is not only to provide good quality care for children close to home, but it also aims to ease some of the backlog of patients that are clogging up our community dental services. And we want to get these patients managed closer to home and relieve some of the burden of care within those community settings who have got quite huge waiting lists post-COVID and even before. So children under the age of 16 will be referred to their local community dental services, and those community services will then triage specific referrals. The services have a list of all of the child-focused dental practices and their postcodes, and if a referral is deemed to be acceptable for a CFDP, a patient will be referred onto your practice. At that point, we will expect a face-to-face assessment and treatment planning to take place, and one course of treatment to be completed, and the patient to then be discharged back to their original referring dentist. If for whatever reason the patient is unable to manage care within your setting, you can send them back to the community services and they will go back to their place on the waiting list. Or if you manage to complete their treatment, which we hope you'll be able to do, they can then go back to their usual GDP. At every stage of this process, we hope that we've made it as easy as possible for you by providing pro formas of letter templates, very easy to fill in guides, so you don't need to do anything too difficult in terms of being in contact with either CDS or your local referring practices. Discharge summaries, everything that you need is already available for you in a package that you'll receive as an onboarding guide to support today's session. Thanks, Jane. So the kind of patients we're expecting you to see and what CDS will be referring to you are children between the ages of 0 and 15 who may be attending with pain and infection secondary to caries. We're expecting extractions of primary and permanent teeth under local anaesthetic and restorations of primary and permanent teeth under local anaesthetic also, and including the use of preformed metal crowns with or without local anaesthetic, so using the Hall technique. And obviously there's a training module specifically with regards to the Hall technique to support all of this project as well. You've been provided with some kit, or you will be provided with some kit to support some of the methods we want you to practice in day-to-day life, including use of the wand and silver diamine fluoride, which I know is quite a novel technique for some of you, but I really hope will change the way in which we manage and treatment plan our patients going forward. If you feel you're not having too many patients being referred into your service, the CFDP email address, which I know you all have, please let us know. Or alternatively, you can feed it back by one of your peer support sessions. But if you feel it's too much, you need to let us know soon, then drop us an email and we'll be able to manage that by contacting the CDS service. And the same if it's the other way. If you're getting too few patients, do let us know and we can direct more patients into your area. Thanks, Kulshana. So referrals will be received by either the Whittington service or CLCH Community Services. The expectation is that the CDS will then refer on that specific referral to the practice which is closest proximity to the patient's postcode, and it will be sent via an nhs.net email with a heading saying CFDP referral. If that patient needs to be sent back to CDS, if the same email trail can be used, that would be really great. So we'll be able to track each referral coming back in to and from the system. So I know you've provided all of your email addresses. We might be waiting for one or two more, but this is the way in which we would like the CDS to be able to send patients into your practice. Thank you, Jean. If you or when you contact a patient to attend for their appointment with you, we'd be grateful if you'd be able to share with them a patient information leaflet and let your practice staff who are making the phone calls aware of the scheme understand what they need to tell the families, which is, you've been referred to a child-focused dental practice and we're here to support the community dental services, and we have additional skills and tools to manage your child closer to home. And if you're able to share this via email or text message, and we also have a QR code as well. So when families come to see you in a practice, they're not surprised why they're not going to community. They're aware of what a CFDP is, that it's a pilot scheme and that will only be lasting for 6 months. So we'll give you access to all of this information and the leaflets as well. Thanks, Chief. Once you've accepted the patient in your practice, the intention is we'd like you to contact them at least 3 times before you say that you haven't been able to make contact. And if it's an urgent referral, we would like them to be seen ideally within 48 hours. And if it's a non-urgent referral, to contact them at least within 2 days of receiving the referral, and then see and treat them within 3 weeks of receipt of the referral. If you are unable to contact the patient after trying 3 times on 3 separate occasions, then we're asking you to please send a letter back to the community dental services through that same channel of that email trail using the failure to contact template. All of the letters I'm talking about in the templates are part of your onboarding guide. So that's a pre-written letter. You just have to put some information in of how many times you've contacted the patient. Thank you. We have this slide in here about safeguarding because it's really, really important. We always keep safeguarding at the forefront of our mind. And I know we do it anyway on our day-to-day basis. But just to reassure you that sometimes if you do have an odd case or you've found it difficult to get a family in, or even when you see them, something just doesn't ring correct. I know you all have your local governance throughout your practice settings, but please feel free to either contact any of our team here or to talk about it in the peer support sessions. Again, sometimes if something doesn't feel right, often something isn't right. And so it's worthwhile just talking about it. It never hurts to talk about these things. So just remember safeguarding with all of these cases, please. And remember that we're talking about not a DNA, but a was not brought for all of our child patients. Thank you. I'll pass you on to Gulshana now. Thanks, G.
Thank you, Ush. So like Ush has mentioned, so once you receive a referral from the CDS, you will be expected to carry out an assessment. And once an assessment has been carried out, a treatment plan can then be formulated and then carried out. So the types of treatment that we'd be expecting the CFDP practices to be carrying out would be including prevention. So that would be a lot of the things that you must be already be doing in your practices and part of your general dental practice. So that includes oral hygiene instruction, diet advice, fluoride varnish and fissure sealants. You may be also expected to stabilize the patient as well. So that can also be carried out via silver diamine fluoride. And that will be part of the equipment, that we will be sending out to all the practices as well. You may also need to provide some temporary restorations or more definitive restorations, such as whole crowns. Again, the preformed metal crown kit will also be provided as part of your equipment too. And you should be receiving that over the next coming weeks as well. In terms of, again, the types of treatment that you'll be expected to provide, that will also be extractions possibly. And that may be due to possibly one offending tooth, and the rest of the treatment may need to be carried out somewhere elsewhere. So for example, if you're not able to carry out all the treatment, you may be able to extract that one offending tooth and then refer that patient back into the CDS. And again, if that needs to be done, there is a letter template to do that as well. So in terms of if your patient can't cooperate with any of the treatment, there is a letter template called the CDS failed treatment letter. And again, that will be part of your onboarding pack, and you should be able to send that across to the CDS via the email chain that they originally gave you the referral from, so they exactly know what referral that corresponds to, so that patient can be contacted and further treatment can also be carried out as well. We've also created some parent information leaflets for you all. So that includes advice for 0 to 3 years or kids that are older as well. It does include information with regards to preformed metal crowns and STF and post-op extractions as well. So it's a great tool and a great information leaflet for you to use for all of your patients as well, just to make sure that the parents and the patients are fully informed in terms of the treatment they'll receive, the risks and benefits of the treatment, and in terms of what they should expect for the treatment too. We also do have leaflets with regards to inhalation sedation and intravenous sedation. So, and I can appreciate you may not be offering that type of treatment in your practice, but for example, if that patient needed further treatment to CDS, you can provide those leaflets and that information to them if they did require that treatment in the future. So again, they are fully aware of what to expect when they do get to CDS or even in the hospital setting too. Okay. So after you complete a discrete course of treatment, usually, hopefully, the patient will be discharged back to the GDP. And if that is done, so whereas all the treatment that needs to be completed is completed by yourselves, there is a discharge letter template for you to complete. So there's just a screenshot of that just at the bottom right. Again, we've tried to make it as easy and as user-friendly as possible. So it's just a case that you do just need to fill in the details and basically put in information with regards to the treatment that's been carried out. Or, for example, if you weren't able to carry out any further treatment or any future treatment they may possibly also need. If, for example, you haven't completed all of the treatment, so part of the treatment, needs to be completed by another clinician, and that could be in the CDS or the hospital services, you will have to use the failed treatment letter, and in that case, that letter will go back to the CDS so that, again, they're aware of all the treatment that's been completed and any outstanding treatment that needs to be carried out as well. So in terms of contractual arrangements, so a CFDP variation will be issued to existing GDS and PDS contracts. So a specific entry on Compass will be created for the submissions of these claims and payments to the practice too. So all CFDP activity must be submitted through that dedicated contract entry on Compass. And we have Andrew here on the call as well, who will be able to discuss or kind of answer any questions you have with regards to contracts and payments too at the end of the presentation. So one of the things that we will be asking all CFDP practitioners to carry out will be data collection. So we've been working very closely with a health economics company to develop a data collection sheet, which hopefully will be quite easy and quite nice for you to use to ensure that all patients are recorded so that we can accurately record each patient that's come through via the CFDP referral pathway and the type of treatment that they've had, or for example, you weren't able to carry out treatment and where they've gone to. So far, like Osh said, the CFDP scheme has been running in the southwest and the east of England, so we've had quite good feedback so far from the teams in those regions, and hopefully it's been quite easy and quite nice to use. So I'm just going to flip my screen to the actual spreadsheet itself, just so you can see exactly what it will look like. So essentially, it is an Excel spreadsheet, and on here, we do expect you to put a patient unique identifier. So for example, it could be the R4, or for example, if depending on what kind of system you're using in your practice, or it could be the SOE kind of number or identifier that is assigned to that patient. And for every patient that you see within the CFDP referral pathway, that patient has to be recorded via this spreadsheet. So if you just make sure that you use that unique identifier, it just makes sure that we can always kind of track multiple identifiers per that course of treatment as well. So for example, if a patient is seen 2 times or 3 times, that patient will still need to be, or that episode of care will need to go on each data collection entry, so that we can see how many times they've actually had to go through before they've completed their course of treatment. So the beginning of the actual data collection sheet it's very much the demographics that we expected you to record. So that can be done either by your admin team or by your receptionist. So hopefully if you can try to recruit as many of your team as much as possible to try to make it as easy for you as possible too. In terms of the things that we would like to record, it's mainly due to the reason for the referrals, when they were referred, the types of treatment they carried out as well, and if, for example, you were able to complete all the treatment, or if they needed an onward referral to, in this case, they had to go back to the CDS and they needed some further treatment as well. So this data collection template sheet will also be shared with yourselves as part of your onboarding pack, and you should be receiving that again within the next week or so. So I'm just going to go back to the presentation. Again, as part of the feedback and the evaluation process, we will be asking all patients that are coming through the CFDP pathway to actually fill out a feedback form. So this is a feedback form that is for the parent, and we have a slightly child-friendly one for the child as well. So the feedback form, it's something that you will have access to, and you can either do it via online. So if you have an iPad or a CliniPad in your practice that you can potentially use to kind of save paper, by all means, you feel free to do so that way. Or if you want to, you can always print those kind of feedback forms out. And what we will be asking for is on either a 2-weekly basis for you to actually send these feedback forms back to us. If you have scanned them in, that'd be really great. And we have an email address that we'll be able to send those feedback forms to. We will also be asking a sample of the patients as well to come forward and have semi-structured interviews. So there is a box towards the end that basically just says, if you are happy to take part in a short phone interview, please tick this box. And so we'll be asking some of the patients or the parents who provide their phone numbers and email address. And then we will be contacting those patients as time goes on to ensure that we have that semi-structured interview, just so that we have more of a deeper understanding on their experience of CFDP and how that has been different compared to, for example, how would have been normally treated. So this is just an example of the patient feedback form. So this again looks a little bit more child friendly. So it has more smiley faces, as we can appreciate the children that you'll be seeing will be fairly young. And hopefully it'll be a quite nice and easy way for the child to actually kind of evaluate or kind of assess if they enjoyed their treatment or if they enjoyed their visit on that day too. So we will also be asking feedback from yourselves as clinicians. So in terms of the clinician feedback that we'll be looking for will be via a baseline survey. So you will receive a link to the baseline survey by next week, which essentially will kind of capture how the current GDPs or dental therapists are confident and competent in dealing and managing pediatric situations. This will also be followed up at month 3 and month 6 as well. We will also be asking a small number of clinicians in the region to also take part in a semi-structured interview. Again, it's more to kind of get a deeper understanding as to how they benefited or if they have benefited from all the online training, the webinars they receive, and the peer review support, that you'll also be provided with too. So going to the peer review sessions. So these peer review sessions will be held once a month, and they will be done via Microsoft Teams. And the actual dates and the schedule of it will also be provided in your onboarding pack as well. So you should receive the dates for that too. So it's really important that everybody who has been taking part in CFDP attends the peer support, because the evaluation is just not looking at the children's experience themselves and the impact that it's had on them. It's also looking at the impact that it's had on yourselves as clinicians to see whether there has been a confidence and competence gain in terms of seeing more children coming through that CFDP pathway and having all the webinar training and the online training too. Like I said, they will be virtual, and hopefully we'll be keeping them outside of their clinical kind of time. So hopefully all should be able to attend. And in terms of the structure of them, we do wish for you to bring cases. So just to make sure that it's more of a kind of open forum and open discussion. The peer review sessions will be led by one of the consultants or one of the specialists here at the Eastman. So it will be led with either a consultant or a specialist. And we do ask for you to kind of submit a case if you do have one. And there's a template of the case kind of in terms of what we would be expecting for you to actually submit. And again, that will be formulating part of your onboarding pack. The session itself will usually last for about an hour, and it will be an opportunity for us to discuss the clinical aspects, so via that case, and also the the expertise from the consultant or specialist leading that session, and it also give us an opportunity to discuss management aspects of CFDP. So that can include if you're having too little referrals to many referrals, if you're having problems or issues with equipment and so on. By all means, you can bring that forward to the peer review session so that they can be addressed and can be discussed. If you have any queries that you think should be kind of dealt with sooner, again, please email that CFDP inbox. It is monitored on a daily basis, so hopefully we should be able to pick that up very soon and be able to deal with any sort of queries or any problems that you may have as well. So in terms of what will happen in the next 6 months, so once you have access to all the online training and all the handbook, you will start to receive referrals and provide assessments and treatments for these patients. Hopefully you should be providing timely and accessible care, as these patients will be seen in a location that may be closer to home and hopefully quicker than they would have done if they were still on the waiting list. You will be able to discharge patients with the appropriate paperwork, and we will be providing all those letter templates again in your onboarding pack to hopefully try to make it as easy and as smooth as possible for you all, to ensure that all the paperwork is done without having too much of an admin burden on you all. We will be expecting a clinical log, and that's the clinical log that the data collection sheet showed that I went through, and we will be expected a monthly log of that data collection sheet on a monthly basis, just so that we have it for evaluation purposes and so that the evaluation team can start to start their work on them and start to carry on with that as well. Peer support will be provided throughout the whole duration of the pilot. So that will be via your peer review sessions. But again, if you feel that there's a clinical need or another need that needs to be addressed more urgently, by all means, please do contact us via that CFDP email inbox, and we'll be more than happy to pick up any queries. And we also wish to gain feedback as much as possible as we go along. That will be done via the peer review sessions as well, and also by the patients and parents filling out that feedback form too. So in terms of when the pilot will start, we're hoping it starts in the middle of December, and it will run for a period of 6 months. So it means it will end in May 2023. So in terms of what you as clinician will be getting out of it, is hopefully you will be upskilling the entire dental team. So we would like to use the skill mix in your team, so include dental therapists and yourselves as part of assessing the patient and delivering treatment to that patient too. We also would encourage you to use your nurses who have any sort of extra qualification, for example, in oral health and prevention, to ensure that these children get the prevention that they require, to ensure that they have and keep a healthy mouth too. We will also be providing efficient and accessible care to children, and hopefully again we'll be utilising the team to a full capacity as well. We hopefully would like to receive feedback by yourselves and through the patients as well via the feedback forms that will be created, and having the dialogue and the engagement across the peer review sessions as well. So again, I just want to reiterate, it's really important that anybody who is providing treatment as a CFDP practitioner can attend those sessions, as it will be really valuable, not from just a clinical aspect, but also from an evaluation perspective too. You will be receiving that piece of equipment. So you will be receiving the STF, so silver diamine fluoride, the local anesthetic one, where you will also be having training with that from the webinar. And there is a contact that you can also call from, email from the actual manufacturer company. And what they do is they actually come out and give you kind of in-house training in how to use the one and troubleshooting as well. And again, all that information will also be in your onboarding pack. And hopefully at the end of it, we'll be able to build a network of like-minded colleagues who enjoy managing children in primary care setting, to ensure that they essentially receive the treatment they require in a timely fashion too. So in terms of the next steps, so like I was saying, the next step will be the baseline survey. So this survey will be need to be completed by all of the GDPs and the dental therapists who will be taking part in the program, and a link for that will be sent out to you tomorrow. If you can please complete that by the 1st of December, so that would be really great and just really helpful for us as well. We have a lot of this information anyway, so with regards to the postal addresses, again, it's just so that we can make sure that we have the correct address so we can send out the equipment to you. And again, if any of your practices are in a bit of a location, where deliveries can be difficult, can you just please let us know, because that just makes life easier for us when we are sending the equipment out too. We will like each CFDP practice to have a CFDP lead. So again, it's just one point of contact. For example, if you're having any issues, or if we need to send any sort of correspondence or any sort of circulars out to yourself, having that CFDP lead just really helps, just to make sure that information is disseminated across the entire practice and the entire team too. And then within the next 2 weeks, you will receive access to the handbook. So that will be a digital version. So that will be sent to you via the PDF, and that will include all the links to kind of guidelines or any sort of PDFs or any sort of kind of further information that you require on that link. You will also receive a hard copy too, and that again will be sent as part of your onboarding pack as well. The online learning will also be delivered via e-learning for health. So I've got pretty much most of your email addresses. I think there may be just one or two that might be missing. So I might want to email some of you just with regards to having that email address. And any practitioners that you think may be, or any sort of, if you have a practitioner that may be willing to carry out or go ahead with CFDP, please let us know. It just means that if they wish to take part in the program, they need to have the online training, and to do that we just need to have their email address, just to make sure they have access to that online training via e-learning for health. So that's just really important, that if anybody's thinking of doing it, or they're not sure, or even if they wish to join midway, again, please just let us know, just so we can make sure that they receive that online learning, the online training, and the CPD that goes along with it too. So as I've said, you will also receive a separate CFDP onboarding guide. So it's essentially a 25-page document which has all the processes and the protocols, and hopefully kind of breaks down each step and almost troubleshoots each step as well. So for example, if you're not sure to do something or you're not sure where anything is, that onboarding guide should direct you to the right place, and it will also help to supplement this presentation too. Sorry, so it's a lot of talking for myself and Ush. So now we will throw it to you all. Thank you very much for listening, and if you have any questions, we'll be happy to answer them.
Thank you. Thanks, Gulshana. Before we go to questions, there's just one thing I want to slightly differ to what you say, Gulshana, at the end about if you have any practitioners in the team who want to be a part of the process, please can you put their names down now? The reason being because the whole purpose of the project is obviously because we want to give accessible care for children closer to home, and that's not going to happen long term if we don't show that the project has worked. So the only way we can show it will work is by all of the data collection that we're taking along the way, and there's 3 aspects to that. The first one is the data collection sheet Gulshana's shown, so that's actually the treatment that you're performing for the children. The second one is the patient and parent feedback. If they say they don't like it, it's not going to go happen long term. So we really, really need that feedback from them. If they like it, if they don't like it, what we could be doing different. And also from a practitioner perspective, we want to make sure that we're giving you some increase in confidence and you're getting more competent in what the treatments are that we're providing training for. So all of that is being managed by an external health economic company that will look at things even as fine detail as sustainability and the benefit for families being treated closer to home and not having to travel a distance. They will do that by analysing people's postcodes. So we really need as much data as possible. Looking at the practitioner feedback, what that means is that you will have a baseline survey. So anyone who you think may be interested in your practice, they must fill that baseline survey in now, because later on they can't fill a baseline survey and 3 months later it will skew the results. So even if they choose not to see patients, then later on for whatever reason, that's fine. But anybody who's interested now, please make sure that we get some people on board as soon as possible. I hope that makes sense. G, you agree with that?
Yeah, no, that
Yeah,
absolutely
brilliant.
makes sense. Absolutely, that's fine. Thank you.
Thank you. Thank you very much. So we can stop. We can stop sharing our screen. Andrew, you have a question. Thank you.
Thanks. A couple of questions from me. First of all, thank you both very much for the presentation. It's so nice to see a pilot where I'm not doing any of the heavy lifting at all. Someone else is doing it all on my behalf. So just about returning patients to CDS, I'm assuming our CDS colleagues will be sending patients that you don't think will have to come back to you at all, and that most of their treatment can be delivered in the primary care setting. Is that the case, Andrew and Andrea?
As much as we can assume from a referral, but obviously you can't really tell from the referral. So we'll have a look. We'll see the ones that say carers, but we obviously haven't met these patients, and we're just straight forwarding on the referral. So yes, and obviously not the little ones, and yeah. Yeah.
Okay. So appreciate it's not going to be always easy for you to decide or for you to ascertain what their needs are going to be, but will there be, is there a possibility, and this may have been something you discussed already, for before a patient is potentially discharged back to CDS, for the GDP in the pilot to contact CDS if they require any advice on how that patient's treatment could continue in the high street practice? Or is it easier just to discharge the patient back to CDS? I'm not a fan of patients receiving a bit of treatment here and a bit of treatment there, but I totally appreciate that sometimes that's inevitable.
Yeah. So Andrea, you okay if I answer a little bit of that? So we had a chat, Andrew, yesterday that obviously we don't want that to happen, patients going back and forth as well. So in answer to your first question is that we said what we would do is what we've done in other regions are after the first month happens, we'll do an evaluation of how many patients are being discharged, how many aren't being treated, so we can see if there's any patterns forming. That might help us identify some inappropriate referrals or maybe practices that aren't able to cope with the kind of treatments patients we're sending across. And the second thing we'll always say is that the CFDP team is always available. So without trying to put extra burden, and hopefully long term, the peer support will be something that will be inbuilt into CFDP. So practitioners will always have a port of call to go to. So CFDP team always available if there's any individual questions about specific patient cases, so we can see if there may be something a bit different they'll be able to manage before then going back and sending you to CDS again.
Thanks. So my next question was going to be where a patient's been referred from CDS into a CFDP, and the CFDP has attempted 3 times to contact the patient and there's been no response, and that patient is then sent back to CDS, I think the pathway showed. Does that mean that CDS can then discharge that patient, or are we expecting CDS to attempt to contact them? And before you answer that, I'm sure that all of the practices on here do this anyway, but of course when some patients, when they receive a call from an unknown number, they're not going to answer that phone. So I trust people will be leaving messages and potentially sending text messages as well when they're trying to contact these patients to get them into their practice.
So I hope so. Yeah, agree with you with regards to making sure we leave a message with the patients so at least they know who's calling, or I'm calling you from an unknown number. Andrew, I don't know if you want to answer the question about the discharge.
Yeah, I think, if it's a was not brought situation, it's exactly the same as if they'd attended the community dental service and they'd not been brought for 2 or 3 appointments. And we have a protocol, and I'm assuming this has a protocol for how many attempts you make. And if they don't attend, it's as if they haven't attended the community dental service and they get discharged. But it's important that the letter goes back to the GDP who referred them, and then everybody's aware what happened. That is really about the communication. I just want to pick up the first point. I just agreeing with Andrea, really. We're just forwarding referrals that we receive, and there is often quite limited information to make a judgment about what level care that child needs. So there is an element of failure built into a certain proportion of the referrals we pass on, and you just have to accept that and send some of them back where they, the first examination, it's clearly not appropriate. Partly also because some of them have been waiting perhaps 4 to 6 months for an appointment, and some things might have deteriorated to the point where it might even need GA, if not inhalation sedation.
So sorry, Andrew, my question wasn't so much about when a patient is WNB, it's when the child-friendly dental practice has tried to contact the patient several times unsuccessfully, and I think the pathway said that then the patient would be sent back to CDS. So it's not a case of was not brought, it's a case of haven't made contact. Are we going to, if the patient has been sent to child-friendly dental practice but won't engage there, do we just say, right, that patient's discharged, goodbye? Or do they go back to CDS and then you have to attempt to see that patient or make contact with that patient?
I don't see the point of us trying to contact them again. I think if people have made reasonable efforts to contact them, and normally what we would do is we would leave messages and say it's the patient's responsibility to contact us to make the appointment, and if we've asked 3 times for them to do that, I think that's probably enough.
So I'm not sure how it looked on the patient pathway, but if that's not how it shows on the patient pathway, could we amend that just to reflect that, please? Because I don't think.
Let's CLCH.
Yeah, no, I noticed that in the presentation because I wasn't sure what extra we would do. If we tried 3 times or as well, and then we send a letter, we ask them to contact us, and then if they don't contact, we do actually discharge, but we copy in the GP and the referring GDP as well. But obviously if there was something with a safeguarding concern, we might take it further and try and contact school nurses. But I don't think we'll be doing anything too different in these cases. If they wanted advice on what to do, maybe it could be discussed at the peer review, perhaps, rather than coming to us again. I don't know what each thinks.
Yeah, no, I agree. And Andrew, you're right. It isn't reflected correctly on the pathway. So I think we change that and also add another letter template in. Sorry, Gulshana, but it will basically be a WNB template for CFDP, which will go to CDS. So CDS are aware that patient has not been in contact with us, and you can take them off your list essentially as well. I'm not sure if we'll be able to include in the GPs if the GP details aren't on the referral. But yeah, I agree. I think that's something that we can talk about in peer review sessions if it's happening quite often, and what sort of concerns there might be in safeguarding for patients who was not brought as well. So yeah, we'll change that and we'll add that in at the same time.
I mean, hopefully all these patients will engage. I just always think of the the one problem that we're going to find further down the line, that's all. But hopefully these will be few and far between.
Thank you. So actually in the South West, what they found is there's quite a few patients who didn't want to go to CFDP. They wanted to be seen at CDS. So we might end up in the same situation again, where you'll get a call and they'll say, no, I just want to wait for my community service. That's all been built into the data collection as well. So they'll be identified if patients don't want to be seen in a primary care setting for some reason. Andrew, did you have another question? No, okay, thank you. Andrew B, we have a question from Robert, who asked about, and we talked about this in the briefing event as well, about accepting internal referrals. So it saves a patient having to go to CDS and coming back to a CFDP. So at that session, you'd said that would be okay to do that. And I think we modified our data collection to show where the patients are coming from. So whether they're coming from CDS or whether it's an internal referral. And, you know, we don't want all the patients to come internally, because that defeats the purpose of the pilot. But for some odd occasions, it wouldn't make sense for them to go out and come back in again. So are you happy with that still?
For the purpose of the pilot, yes. I mean, we all know that under the mandatory services contract, Crown halls can be delivered. We know there are lots of reasons why that doesn't happen now. This is the point of this pilot, is to see what we can do to change that. I would be concerned if I saw 50% of a practice's capacity being used for internal referrals, because if you've got that number of patients that need this treatment already, and they're on your waiting list, what were you going to do with them? So if you have a patient who is suitable for an internal referral, that's fine, and make sure they're marked, make sure the FP17 reflects that. But if we see large numbers of that, I'd want to understand what the rationale was behind that.
Yeah, thank you. Thank you. Robert, does that answer your question?
You're not going to get in trouble for any of this. It's a pilot. The whole point of the pilot is for us to find out what we don't know. We know that hall crowns are effective. What we don't know is how we get people to deliver them. So that's what the pilot's for.
Thank you. And yeah, just to reiterate about the internal referrals as well. So this is a kind of a build on the CFDP project that happened in Greater Manchester, and they showed that 50% of the patients who went into CFDP then didn't go back into CDS. That's quite a huge number of patients that they saved going into that pathway. So we really don't want them all to be internal. We want to really help CDS where possible as well. In relation to the question that you had, Andrew, about referrals, inappropriate referrals, or, you know, it is very difficult to triage from a letter as well. So in the Midlands, they did a spin-off of CFDP as well, which they've not carried on long term, but their patients went into CDS, they were seen in CDS, treatment planned in CDS, and then sent back out to CFDP. So they didn't have enough time to do an evaluation or data collection. But I guess looking forward at models, that is something that might be written up in the evaluation as well. It doesn't help the kind of burden of a patient waiting for that treatment plan in a CDS setting, but it might mean that things are more effective when they get into CFDP then. So something else to think about. Next year's project, put it that way. Thank you. We've got a couple of questions in the chat. Quick question, 10-year-old file number 6s, advised to have XLA prior to ortho. Who said he can see if she has disability? What should the college do as hypermineralized 6s? I think if they are in pain, I think that's Maggie, I think. If they're in pain, then you could, too young, and Whittington says, I'm a bit confused. Andy, is it okay if we, Maggie, sorry, if we can take this question offline and I'll speak to you about it separately, if that's okay?
Yes, that's fine. Sorry, it was just a peer review colleague
Yes,
says if I wouldn't mind asking.
Yeah,
Thank you.
I'll talk to you about that separately if that's okay, because I think we might be able to have an answer to that one if that's all right. I have another question about submitting claim from silver diamond fluoride and hall crowns. Do they appear on FP17? How do we submit for those?
I'm not sure. I haven't looked at the new version of the FP17, I'm ashamed to say, and I don't even know if it's out yet. All I know is that the contract changes that are happening are causing me no end of trouble with our endo contracts because of the 7 UDAs for endo. It may well just appear as other on the FP17, which is why it's really important that you fill out the spreadsheet which details what treatment is being delivered for these patients. So I'm afraid I don't know. I mean, your software will record it, and I know that they're looking to try and get more information on the FP17 from the software, but I haven't heard about that.
Again, Robert, we can talk about that again, and please, any questions which we don't answer today, we will hopefully get back to you and maybe send some question and answer from this session as well, from things that are in the chat. Do we register all patients on R4? Whatever system you use, yes, please register the patients at your practice. Ashish, please. Perhaps I've missed answer. Once a patient has been booked to attend and they are not brought in, do we offer them a further appointment? How many chances do they get? So I guess, Ashish, that depends on your usual practice protocol for patients who don't attend. So I wouldn't give any extra kind of advantage of these patients over other patients because they're coming from CFDP. They're a patient, you've booked your time off in the diary, and they will have physically made an appointment with you on the phone. So if they're not coming into their appointment, then you would give them as many chances that you would usually give your patients. I think it depends on if you have any safeguarding concerns, which I'm sure if CDS team have any really conscious ones of safeguarding issues, you wouldn't be referring them to CFDP. You'd probably keep them in-house anyway. So I would follow your local protocol with that, please.
Thank you.
Yeah, the only exception I could think to that would be for a child looked after, that I might be a bit more forgiving for a child looked after, but I don't know if you'd be sending them on anyway, and we've got a children looked after pilot running, so that may be the only place where I might say sort of 3 strikes rather than 2, if that's your practice policy.
Yeah.
Sure. Thank you.
Yeah, Ashish says that's fine. So I think again, I'm not sure, Andrew, if you want to have a conversation between you when you speak to your triaging team, if you have any safeguarding patients, maybe you want to keep them in-house, or perhaps if you send them across, we can have a policy. And I'm sure everybody knows with the looked after children, we will give them an extra chance just in case, because obviously they're not with their own parents, but we can have another conversation about that and maybe think about putting something in the onboarding guide about making sure if they are a child with a safeguarding need that we've followed up appropriately and don't discharge after one visit, just so we have that safety net.
Yeah,
Andrew?
we wouldn't send any patients knowingly where there was a safeguarding concern, but we are forwarding emails. Children who've got most of the caries tend to be in that cohort of the population where there may be potential safeguarding needs. So I think it's about all of us being aware that there are potential safeguarding issues for any other patient other than the ones who are labelled as safeguarding.
I agree with that.
Sense.
Yeah, because we often don't know from the referral, and it only becomes apparent on the actual visit, if that makes sense. So I think that the people in the you have to be aware in the practice as well, but we would never knowingly forward it on.
Yeah, thank you. Ali, you've asked some questions about restorative items here. If I can suggest any specific clinical questions, after today's session, you'll have 2 weeks to access all of the webinars and the online training. And then if there's any specific questions from a clinical aspect that still remain, contact the CFDP inbox and we can have individual conversations with you. I think you'll find, Ali, we're not asking you to do pulpotomies or pulpectomies, so I wouldn't worry about the restorative material at the end of it. So definitely do the training first, and then we can have clinical questions. I hope that's okay with everybody. Otherwise, we can talk about clinical aspects all night of things. Okay, next question is, do we transmit all claims? Would it appear as part of our UDA number or separately?
So I will be creating specific contract entries on Compass for this activity. So you are having we will issue, let me start from the beginning. There's a contract variation for this activity which will be issued to all participants. That is a contract variation to your existing mandatory services contract, and that will normally be GDS rather than PDS. I will create an additional contract entry on Compass, and all FP17 activity for this pilot needs to go through that dedicated contract number. Now, I know that at some point an FP17 will be processed on the wrong contract. That's happened an awful lot with urgent dental care. You can always recall them and we can submit them on the correct contract number. I can put windows on in case it's a late claim, so don't worry about that. But yes, everything will go through separately. This will be, I can't remember what I put about reconciliation, but it will be treated totally separately to your main contract. So yeah, they will not appear on your activity of the contract. And before we go on, so the next question, I had just looked at that. So children who need sedation, one thing I heard from a lot of people during the depths of the pandemic was that given time, a lot of patients were able to manage with a lower level of anesthesia than they thought they needed, because one, it may not have been available to them, and just by working with the patient they were able to maybe move from GA to sedation or sedation to LA. And I know that's not the case for really anxious patients or phobics, but before clinical colleagues answer that, a part of this pilot is about taking the time with these patients to see how much we can deliver in primary care rather than automatically go to CDS. But I'll be quiet now because it's more clinical.
No, totally. And actually, leading on from that was Anna's question. So Anna, your question alone tells me that you are the right type of person to be doing this pilot. If you're the type of person that only refers severely anxious children, and you would be surprised the number of patients that go to CDS that probably potentially could be managed in primary care. Correct me if I'm wrong, Andrea.
No, that's correct. I mean, but you can't always tell from the referral, but yeah, there are lots haven't actually ever had anything tried or attempted. And actually you can do some treatment with local and just crowns, or they don't need, sedation, but it's obviously you can't tell from the referral, and so a lot do. So there will be a mixture that will be sent back, I can imagine. But there will be some that can be treated in practice, and it will be interesting to see the numbers. And I think that's the whole purpose of the pilot, isn't it? So I'm not sure if Andrew has anything extra to mention.
Yeah, I mean, I think implicit in the training, I mean, it isn't, I don't know whether it's a module, but being able to manage a normal child who's just got normal levels of anxiety, just like any member of the general public, is key, really. And we wouldn't expect those to need anything more than a bit of time, TLC, and very, very obvious behavior management techniques long before you ever get towards doing sedation, because actually sedation relies on those things as well, if it's inhalation sedation. So I think it's those, shall we say, softer skills which are probably the most important in the patients that will be sent to you.
Yeah, and there
is the ones as well, aren't you? So the ones is like a massive extra bonus as well. So yeah, I think there'll be a lot that you can do.
Yeah.
There is a module on behavioural management as well, which has been delivered by one of the colleagues at the Eastman. She's absolutely brilliant, and I think you'll find it really interesting and engaging. And there were tips and tricks, and actually a part of this is treatment planning a patient appropriately. You might see a child with gross caries and all D's and E's and think, oh, they need a GA. But actually, if you can stabilize everything, and if they have one tooth that needs to come out and you manage that one tooth which is causing pain, the other teeth, if you stabilize them correctly, so for example, even using something like SDF, they may exfoliate without any problems. If you just manage the prevention aspect, they don't always need all D's and E's taken out. And that's, again, all built into the webinars. So the treatment planning, the peer support will all become a part of this. So I think it's about changing or reframing your mindset. And when you see a child with gross caries, don't think, oh, they need a GA. It's often not the case. They can really be managed, and we don't have to think about everything in one go. It's about staging those things as well. Hayda's asked a question here about crowns. It's unfortunately, it's a one-off. If we had an unlimited pot of money, we would keep on sending you things, but unfortunately, it's just a one-off set of crowns.
I like that you're that optimistic, Hayda, but if you run out of the whole crowns before the end of the pilot, and I need to see evidence that that all these patients have gone through, I will find a way to buy more whole crowns for you if it's not in Ushi's budget.
Yeah, and we'll give you a certificate as well. So that would be amazing. Thank you. And Robert's asked a question again, Andrew, probably for you, about access to urgent care. So is the variation going to be similar to the access to urgent care variation that happened in January, March? FP17, you have a drop-down box and submission as a variation.
No. So when I'm talking about a contract variation, I mean it will be a schedule attached to your paper contract, which will say for the period of 6 months from this date, you will be a CFDP practice, and there are this number of UDAs or sessional payments against it. So it will detail the contract. So when you're submitting an FP17, you would just submit it as you would on your mandatory services contract. So nothing's different at all. It is think of the Compass entry as a separate contract. But all the usual rules of your GDS contract apply, because I've seen further down. So yes, you have to do the PR form, FP17. So all the usual paperwork accompanying a course of treatment has to be done. When you examine the patient, all the treatment that you identify as being required has to be done. If you can't complete it all because the patient needs sedation, for example, then that's when they get referred back to CDS. But this is, although it is a pilot, all the usual rules of delivering mandatory dental care apply, mandatory dental services rather apply, but it just goes through a separate contract number on Compass, and that keeps the data clean, so we can get the BSA to do stuff for us. We know exactly who's gone through, and for any sort of payments as well, it keeps it clean for me.
Thank you. I don't think we have any more questions. Oh, Robert says he's not sure. He doesn't understand.
I can discuss this with you. I mean, what I've never submitted an FP17, so I'm not clinical. I don't have access to dental software. If you've got software, you should be able to just link this new contract number onto your software. So when and forgive me if I'm getting the terminology wrong, but when whoever it is that submits the bundle of claims to the BSA through your software, you would just put a bundle of CFDP claims through on that specific contract number, and that's how they get processed. So
I think he's got it now.
Yep.
So you can get a different contract.
Yeah, you won't get a new paper contract, but you will get a contract number from Compass, and I'll create that. I'll need individuals to go on and attach the performers who are going to be delivering care. If you let me know, I can then go back in and approve those performers have been attached. Because this is regular activity, it is superannuable. So anybody who is delivering the activity under this additional part of the contract, if they want to make superannuation contributions, they're entitled to do so. The other thing I was going to mention, so where we've got the, what are the two types? We've got UDA at session. Where we have a session, that patient can come back multiple times. It's going to be one course of treatment. It's not going to affect you. But I was thinking about where you have, so let's say a patient comes at the very start of the pilot and you do everything that they need doing, but 6 months down the line, that patient could need something else. What's the plan with those patients? Could they come back to the CFDP and have treatment again under the pilot service? I would have no objection to that, but I don't know what you think, Ush.
After the 6 months?
No, within the 6 months. So let's say a patient needed treatment again. Hopefully not, but
course of treatment.
yeah.
Yeah, I think so. They treat it as a separate entry. The patient might have the same identifier, but it would be obvious that there's been a big gap in between, and so it would be treated as a second course then, because they could potentially do that as a second course within 6 months.
And I have no problem with a patient being seen twice in 6 months. If that's what's clinically necessary, that's absolutely fine.
Thank you. Right, everyone, we've got 1 minute left. Thank you so much, everyone, for your time. I know there was loads of questions. There might be some more. Andrew, do you have a question?
Yeah, just one quick one. I can't remember whether we discussed this previously, but is there a kind of an expected or sort of optimum level of number of referrals per practice that the CDS should be sending per week?
Yeah, so actually, Andrew, that's very important because different practices have requested a different number of sessions. Some have offered 1, some have offered 2. So what we will do on that spreadsheet we're giving you, we will write how many sessions they're doing and the expectation of the number of patients. So it's between 6 to 8 patients per session. And they don't, and they might not be seeing 6 new patients. There might be a mixture of news and mid treatments as well. So I guess we'll have to keep that in mind. But yeah, that's important to share with you, the number of sessions each practice is doing. So we'll put that on the spreadsheet as well.
Okay.
Thank you. Thank you very much, everyone. Thanks for coming, and we really look forward to getting to work with you. Anna will be in touch for our one-to-one meeting, and you've all got the rest of your evenings back, 7 o'clock. Thank you so much, everyone. Take care.
Bye. Thank you.
Bye.